From the Zoomerplex in historic Liberty Village, theZoomer, hosted by Marissa Lennox.
Welcome to theZoomer. I'm Marissa Lennox. Beyond the pursuit of a radiant smile, caring for your mouth, teeth, and gums is essential for your overall health, physically, mentally, and even for your respiratory system. As publicly funded dental care rolls out in Canada this year, it is evident that our government recognizes this too, but there are questions. What is covered? When are you eligible? What if your dentist is not on board? On today's show, we'll seek to answer these, but first, let's get to the core question. How does the health of your mouth affect your overall health? Let's bring in the panel. I really appreciate you all taking the time away from your own practices and your work. Dr. Somerville, I'll begin with you. I've heard it said that there is no health without oral health. Can you explain that? Would you agree?
Certainly, I would agree. I think that, I'll give you a good example. My mother's 89 years old. She had a fall in October, and she knocked out 4 or 5 of her front teeth, was 2 hours from an emergency room in rural New Brunswick, and ended up in the emergency room with a split lip, glued together. And it wasn't until 2 weeks later when we got her home to Toronto that Dr. Rittenberg and I spent hours in his chair trying to fix her up. And that was not only functional, but who wants to walk around missing 4 or 5 of their front teeth? She didn't eat for 4 days. Wow. Because of the damage. She couldn't close her mouth because of the fall, and going to the emergency room wasn't a solution. They put crazy glue on her lip and didn't address her dental issues whatsoever. So I think that's just the start of the whole issue.
Absolutely. I was in the dental chair just a couple of weeks ago, Dr. Shu, and it was interesting because the hygienist said to me, do you brush your teeth twice a day? And I thought, well, isn't the answer to that so self-evident as an adult? Of course I do. If not, it's 3 times a day or 4 times. And she said, you would be surprised how many people answer no. Like how many people brush their teeth once a day or not even at all. And it got me thinking, why is there this disconnect between what we know we should do and what we actually do? I mean, even something as simple as flossing.
When we tend to take care of ourselves, we may not always do what's necessarily best for us, and we tend to neglect ourselves quite a bit. And I think with teeth, as long as they're functional and they kind of look good, then we are self-placated there. But the results for not doing so are, you result in infections and pain and other issues as well.
So maybe it's sort of a misunderstanding about the actual link between your oral health and your overall health. So let's break that down. What is a healthy mouth?
A healthy mouth is a mouth that's free of disease. A healthy mouth is free of germs and bacteria, and so it's really important to maintain a healthy mouth with regular brushing, not only with home care, but also going to your regular dentist.
Dr. Rittenberg, as somebody who sees the aftermath of neglected dental care on a daily basis, paint a picture for us day to day for you.
Yeah, so I mean, my view's a little skewed and biased because I'll see the patients who are at the end stage of the problem, the massive abscesses, infections, problems that can be acutely life-threatening. And so I think, the problem is, and Crom, mentioned it, is that until there's a problem, we don't know there's a problem. And inside our mouths, it's hard. We can look at ourselves in the mirror every day. We can feel lumps and bumps. We can't really see what's going on in the mouth. And things can blow up. They do blow up pretty quickly. So it's interesting how dentistry disconnected from medicine probably well over 100 years ago. And I think to try and reconnect the two, and we're doing it, we're making good strides, is really important.
But spell out the benefits for us, Dr. Somerville. I mean, beyond just having pearly white teeth and...
Well, I mean, if you don't have teeth, you can't chew your food properly. And you can't digest your food properly. So I think, and there's so much technology now in dentistry that allows us to give people their teeth back even if they've lost them. So, and talking about the brushing, I have a 16-year-old boy at home, and I'm not sure he's brushed his teeth since last weekend. And my wife is a family doctor, and I can tell you when she sees you as a patient, she kind of looks right past your teeth and doesn't even really see that there's teeth there unless there's something dramatically terrible that she may even ask me about. But I mean, it's hugely important. If you don't have your teeth, there's so much missing.
We've been talking about gaps in oral care and also the consequences, a little bit of neglect, which we will get into. But maybe you can speak to if, in fact, they're more pronounced in certain communities, particularly communities where there's a lack of access to dental care.
Yeah, that's a great question. There's many gaps in our health system. We know that we can get pretty good coverage when we go into hospital and see our family doctor, for instance. But as soon as we need care outside of those two settings, we have to face a lot of financial barriers. So dental care is probably the best example of that. And the people who face the most barriers to access are those who can't afford to pay. So the lower income communities are going to be disproportionately affected by both the access problems, but also some of those resulting health issues that we've been talking about.
All right, hold that thought. We're going to pick this up on the other side. Don't go away. Welcome back. Oral diseases like tooth decay and gum disease are some of the most common non-communicable diseases worldwide, and yet are largely preventable. Consider this: 7 out of 10 Canadians will experience gum disease at some point in their lives. But of the 2/3 that show bleeding or inflamed gums, almost half choose to ignore the early signs. Dr. Somerville, I was taken aback by that stat. Why might that be it? Because, of course, if there were bleeding anywhere else on our body, that would be something that we would likely get checked out. But why do we ignore it when it's in our mouth?
Well, it's easy to ignore things that don't hurt. And oftentimes with gum disease, there's no pain. With bleeding gums, you could almost argue that it's a bacterial infectious disease. It's probably the human normal condition, right? To have bacteria in your mouth, and they will tend to cause disease. And you leave things long enough, and certain conditions have to exist so that you get the actual disease process that happens. So. But mainly with gum disease, it's one of just not having pain, that people just don't tend to address it.
It's also oftentimes, not always, there's a list. It's not just it's rare for someone to just have bleeding gums and gum disease. There's usually 5, 6 other comorbidities they're dealing with. And again, it's that priority list. The mouth, for whatever reason, often takes a back seat. And so a lot of patients are dealing with so many other things or neglecting all things until it becomes a huge
So what are
issue.
the factors then that might contribute to gum disease?
Well, I think there's lots. I think probably, and you can speak to this, probably some of it's education, socioeconomic issues, access to care, dealing
Is age
with
a factor?
I think it can be. I think we can see decline in oral health as one ages. Tactile abilities change. Again, other health issues come up that just begin to take priority.
So Dr. Somerville mentioned we all have bacteria in our mouths. This is very normal. At what point does the bacteria become a problem?
Bleeding in the gums, I always tell my patients, if your gums are bleeding, you have pink in the sink when you're brushing or flossing your teeth, you should use this as a measure of the inflammation and the problems that might be present. Because all gums and teeth, when they're brushed and flossed, shouldn't be bleeding. So the bacteria that can reside there, their byproducts can produce endotoxins. We've seen this in patients with dementia. We've seen this in patients with diabetes, with cardiovascular disease. At the hospital, we screen for patients, and they're sent to us prior to their heart surgeries to make sure that there's no active dental disease in their mouth prior to undergoing things like valve replacements.
Why is that? Where does the bacteria go? Once it gets into your bloodstream, it's sort of like a bus. It picks up the passengers and takes it to the various organs. What are the organs that are most vulnerable?
So it'll seed to any diseased organ. So diseased heart valve, where there's turbulent blood flow, that's where bacteria will sit and vegetate. Prosthetic joints, a little bit more of a controversial issue now, but at one point they were thought to be a potential spot for seeding. When we see it a lot.
And study after study has shown links between gum disease and cardiovascular disease. What do we know about that relationship, the connection? Is there a correlation? Is it a direct causation?
There is some causation, for sure. And we're seeing this, we're able to track some of the oral flora into actually areas of diseased heart valves, There's definite direct links between really bad infections of the mouth, where patients might develop sepsis, affecting any end organ in the body. So yeah, there's certainly a link. And that starts even before infection, even, a certain inflammatory load, what it does to your body impacts areas far beyond the mouth.
So for people that are listening, how do you know when it's too much blood? How do you know if it's just a little nick from flossing versus gum disease? When do you know that there's a problem?
Well, I think you need to be able to go to the dentist, and there's certain measurements that we do when patients are in for their cleanings, and that's the job of doing your annual visits or semi-annual visits or however often. And in most of our practices, we would tailor your appointments on how your mouth looks. So in Maria's office, she may see people say, I need to see you 4 times a year versus just every 6 months. Mm-hmm. And that's generally addressed by the hygienist and that part of the team.
Mm-hmm. I usually tell my patients, most often we're really quick to take our cars for an oil change, whereas we don't really come to the dentist to have our teeth cleaned. Mm-hmm. And so, your car is only going to last you 10 years. You're hoping that your mouth can last you a lot longer than that.
All right, quick break. On the other side, tooth loss, the health risks it brings, and what you can do to prevent it. Next. Welcome back. A recent study out of New York discovered that the more teeth you lose, the greater your risk of cognitive decline and dementia. This extensive study of 34,000 U.S. patients found that individuals who had lost teeth faced 48% higher risk of cognitive impairment and a 28% higher risk of dementia compared to those with all their teeth intact. Dr. Rittenberg, it is part of a growing body of research showing the link between oral health and other conditions. So first of all, what can you tell us about this correlation or connection, if you will?
Yeah, I think it's very similar in a lot of ways to, we know that hearing loss is associated with cognitive decline and dementia. It's similar, and I would say that it really depends on what teeth you're missing. If you're missing a tooth that's not particularly functional or an aesthetically positioned tooth, probably missing that tooth won't have an effect on your cognitive abilities as you age. But if it's an aesthetic issue or a functional issue, if you're dropping out of society and socializing because you're missing teeth, you're not interacting with people, nutrition becomes affected, these are the supposed links between tooth loss and cognitive decline and dementia as we age.
Dr. Shu, you too are an expert in the preservation of teeth. Why would you say it's such a big deal when someone loses one?
I mean, for a number of reasons. The functionality, as Brian was saying, is a big one. And that's sort of the message we try to drive when you have a patient that's considering whether to try to keep their teeth or lose it. And so we can, as an endodontist and root canal specialists, that's one of the things we try to do. And when someone says, well, it's a back tooth, I don't really see it, so I don't really need to worry about it. I ask them, well, what about the function of this tooth? Certain teeth are there to help preserve other teeth, to help you chew, to help you, with other functions there. So I try to bring that up, and that's when sort of there's a switch and the patient realizes, maybe there is an importance to keeping it. And it's also very patient dependent, because certain patients will have teeth that aren't really functioning. And so those are the teeth where I would say, look, this one doesn't really do much for you. Mm-hmm. It's fine if you lose it. Yeah. That on top of course, the aesthetic portion and being able to speak and chew.
You know, Dr. Rittenberg, Moses likes to refer to you as the implant god. And so talk a little bit about their role in staving off some of the problems we've talked about.
I mean, I think, again, there's the indications for implants. For me, it's always about function primarily. And so that speaks to nutrition, ability to chew. There's aesthetic indications for them as well. And again, I get back to just being able to socialize. Like people, you're missing a front tooth or front teeth. And implants aren't the only way to replace missing teeth.
Well, how do they compare to dentures and bridges? Why would you go for an implant?
What I tell patients is an implant's the closest way for us to give you back what Mother Nature gave you, right? So there are good, and Dr. Somerville can speak to this, there are good alternatives, dental bridges, dentures, none of those compare. And the other benefit to an implant to replace a missing tooth is it really has very little to no impact on other teeth in the mouth, no adverse or negative impact. Mm-hmm. So there's sort of these self-supporting structures.
And dental implants are the single most successful medical procedure you can have done as a human.
Why do you say that?
Because in the vast majority of patients that we treat, you're above 90% success. And so just strictly from a medical procedure standpoint, other than maybe like I get Brian to pull a tooth out for someone, that's obviously going to be successful. But as far as an elective procedure that you can have that's going to do something for you, it's
So you're saying there are minimal risk?
There's always risks, but the risks of, you know, Brian and I work together a lot, and when I talk to patients about sending them to Brian, I'm like, normally if you can tolerate having the tooth pulled or the tooth extracted, then you can usually tolerate having the implant placed, for sure.
Now, why would someone be ineligible for an implant?
I'd say the number one reason would be comorbidities or just, you know, they're not medically fit to tolerate even a minor procedure. That's probably the only absolute contraindication. For an implant to work, we need to have adequate bone volume. You need, you know, general health. You don't want to work in a tunnel. So I don't want to replace a single missing tooth where there's 6 other diseased teeth. But those are all things that can be addressed. The only absolute contraindication would be if someone, from a medical standpoint, can't tolerate the procedure, which is pretty rare.
And further to that, those are the patients that I would see in my practice at Mount Sinai. So these patients with all these extra comorbidities,
and we're treating them,
that might not be able to maintain an implant because even though it's not a tooth, it can still get disease and gum disease and bone disease. But my focus on these patients is to try and retain what nature gave to them with preventive care. Because oftentimes these patients cannot wear dentures as their cognitive status might decline, or for some stroke patients who don't have facial muscle coordination or control that are unable to wear a denture. Oftentimes they have to go without teeth. Mm-hmm. And so once the teeth are extracted, the bone heals, the ridge becomes firm, and they can still mush and masticate their food, but oftentimes the texture of their diet has to change.
And you know what, Sarah, this all brings us back to the importance of routine care, because ultimately implants are a very expensive procedure.
Yeah, of course. I mean, it's great to point out that these procedures are available to us and they're extremely effective, but they're also very expensive. And we also don't want to get to the point where we need them. So prevention is critical, but in our health system, we don't prioritize this. We don't fund it collectively. We provide the minimum amount of public supports for the most low-income people in our society. And most countries around the world have thought maybe the mouth is part of the body and we should include it in our universal health coverage system. So when we compare Canada to other countries, it's really striking that the governments fund less in Canada towards dental care than most other countries in the world.
Most other even
most high-income countries in the world that are compared to Canada. And so we're an outlier.
All right, we need to take a quick break. There's more when we return. Welcome back. Achieving a healthy mouth takes a lifetime of care and involves getting the right oral care products as well as being mindful of your daily habits. So what exactly constitutes a healthy oral care routine? Let's talk some strategies. Dr. Somerville, beyond brushing and flossing, what are some habits that contribute to a healthy oral care routine?
I'd say some of the biggest things I see in our practice is people who we see a lot of teenagers with no disease, and we see a lot of teenagers with huge cavities. And one of the things that it's sugar, obviously, right? But it's sort of how you eat sugar is important to develop decay. So I'll give you an example. We see kids that are athletes, and they're drinking Gatorade all day long, and they don't realize that they're drinking sugar water, and they wonder why they have 20 cavities. And so the same family, in the same house, same routine, we see them every 6 months. The older sister has never had a cavity because she's not an athlete and not drinking Gatorade all day long. So it's just simple things of knowing, and that's really one of the things that we even see, even though we have a specialty practice, we see kids. And they say, see a kid by the time they're 1 year old or the first tooth. And it's not to talk to the child about how to take care of their teeth, obviously. It's to talk to the parents about what not to do. And, I live in Riverdale, and it's a fairly high, wealthy neighborhood, but yet half the kids in my kids' school had little silver crowns because we know that they had to be put to sleep and had partial root canals done on their teeth simply because, parents were putting them to bed with bottles that had something, or they're drinking juice all day long. And so it's habits of how you eat. Sugar is probably one of the most important things that I see.
What role do genetics play?
Well, there's 3 things that you need to make a cavity. You need a tooth, you need the germs, and then you need to feed the germs. So as Dr. Somerville was saying, the sugar-containing foods and drinks in your diet, but also cavities and gum disease is also related to the pre-existing bacterial levels in your mouth, and that's passed down from your parents. And so oftentimes when I'm meeting with a patient for the first time, I'll ask them, what about your parents? Do your parents have a full set of teeth? And if they don't have their teeth, did they get loose and fall out? Meaning that, they might be more predisposed to the gum disease, or were they decayed, had holes, and then had to be removed? So genetics does play a huge role in contributing to the bacterial counts.
That is really interesting, and I do tell that to myself, that it's genetics that are contributing to all those fillings I keep going in for. But Dr. Ashu, what role does saliva play in a healthy mouth?
Well, as Maria was saying, you need germs, and germs create, these bacteria create an acid. And what the saliva does is buffer that acid so that it's not as acidic, not as harmful to the enamel or the surface of the teeth.
Right.
And
So I ask this question because I'm often asked when I go into the dentist, are you on any medications?
Yep.
And there are different things that can contribute to dry mouth.
Well, there are a number of things that can contribute, and one of those is perhaps smoking. That'll give you a dry mouth, whether it's cigarettes or marijuana. Another thing is certain medications can cause dry mouth, and that's probably a bigger one. And certain syndromes. Some people develop these syndromes where the mouth is unfortunately dry, and so you have to work extra hard at maintaining some kind of cleanliness, some kind of salivary flow inside the mouth. And so there are certain techniques, certain medications that can be taken to help with that. But that's a struggle. It's an uphill battle once you have a dry mouth, because as Maria was saying, as long as the bacteria is there and you're unable to control the acid that it produces, now you're going to create holes in the teeth, which is cavities and eventually bigger problems.
And when we have an older population in my practice, we've had patients who've been in our practice for 40 and 50 years. And they get to adulthood, and usually they're not having a lot of active disease, but then something changes usually as we get older. You get placed on multiple medications, you have some medical things happen, and we see the mouth change. Like, we see adults in our practice who haven't had a cavity in 20 years start to get cavities again. And that's when we say to them, we've got to jump on this and be super aggressive with fluoride. be very careful with what, no more Timmy's doubles all day long, because we've got to get super aggressive at preventing the cavities, because you don't want people coming in and just every time they come in, oh yeah, you've got 4 new cavities. And adults get it out the roots of their teeth. So, our older patients, they get all the cavities on the roots of their teeth, which are doubly or much more difficult to deal with.
The big issue is the multiple medications with aging. And so one of the things we'll do as often as you do a medication review, and a good family physician or specialist who has a patient on medication will be, there's alternatives, right? There are certain blood pressure medications. We can offer alternatives sometimes with a simple letter report to that specialist, to the physician, saying, look, we're seeing a problem with xerostomia, with dry mouth. Maybe consider switching from this antihypertensive or blood pressure medicine to another one. And sometimes it's also this sort of synergistic effect. Multiple medications work together to cause a lot of dryness. It's a huge problem.
In addition to our elderly patients and patients on a lot of medications, we've all seen the patients that have had oral cancers that have undergone radiation, and radiation can damage the glands that produce the saliva. And so sometimes it's not as easy a fix as switching a medication. Sometimes we have to rely on different saliva substitute products and high fluoride protocols to help preserve the teeth and also to maintain comfort of the soft tissues, because for some of these patients who have dry mouth, it becomes very difficult to wear, for example, like dentures. It's almost like wearing socks with, or shoes with no socks on. And so it's very important that you teach them how to use all these products that are on the market to help lubricate and moisturize the soft tissues of the mouth.
It's been mentioned a couple times, but fluoride. And I'll be honest, when I've gone to the dentist, I've often said no to fluoride. I thought that there perhaps was a relationship between excessive fluoride and maybe cancer. I'm not totally sure, Dr. Shu.
So I don't think there's any relationship between fluoride and cancer. I think you can certainly, anything that you take in excess can cause harm. And as far as fluoride is concerned, you seriously need bowlfuls of fluoride on a daily to get any type of harmful effect.
Okay.
The fluoride functions, as Marie had mentioned, there's bacteria, and bacteria causes acid. And so that can go through the surface of the tooth, and fluoride prevents that, helps to prevent that. And so if you do have fluoride in your system and you do have fluoride incorporated into your enamel, that becomes a lot harder to do. And so it's less likely that you develop cavities. And so where do you get your fluoride? Well, certain communities have fluoride in their drinking water. You'll see less cavities amongst the people in that community that have fluoride compared to communities that don't have fluoride. And so certainly with children. Now, you can also get fluoride at the dental office when they do certain treatments with fluoride and in your toothpaste. And the amount of fluoride that's there is very, very little and is absolutely not harmful. Unless, of course, you find a way to purify the fluoride and take it in, which is very hard to do. So fluoride is absolutely a game changer that's helped reduce cavities over time.
It looks like all the doctors at the table unanimously agree on that point. All right, stick around. On the other side, what we know so far about the Canadian Dental Care Plan next. Welcome back. As of May 1st, the Canadian Dental Care Plan kicked off coverage for eligible and approved seniors 70 years and older, while those aged 65 to 69 could begin to apply. The program will eventually cover 1/4 of Canadian residents who do not have private dental plans at a cost of $13 billion over the next 5 years. But since the plan was announced in December, there has been some confusion over who qualifies, how the plan affects other insurance programs, and whether enough dentists will sign up to meet the demand. Sara, this is really your area of expertise, so I'll go to you first. Your thoughts on how this program has been first designed and also so far administered.
Yeah, so this program is designed to address the gap that we have in health coverage in Canada. So many people will have benefits from their employer that cover dental care costs, but many Canadians do not. So they're either retired, they've lost their coverage from their previous employer, they're lower income, or they're working in jobs that don't provide the benefits. And so this is, the federal government has stepped in to try and fill this gap and to provide basically another option that is, it's like an insurer for those who have no insurance. And they've partnered with an insurance company to do that. As you mentioned, eligibility is quite strict because it's expensive to cover dental care. We know that it's a very costly sector, but also they're restricting to those who are most need. So eligibility is about income level. So you have to meet a lower income threshold or middle income threshold.
What is that threshold?
It's $90,000 for family income. And so if you look on your tax return, there's like details online on how to figure out if you're eligible. But also you have to have filled in your taxes for the last year. You can't be covered from another private plan. And so those are the main criteria. And then ages, I guess, have rolled out and sequentially. Now anyone over age 65 can apply, and eventually any age group can apply if they meet those criteria.
So where are the gaps? Are there gaps?
So I think, first of all, without question, I completely agree that we're in need of a plan to help provide coverage to those who don't have coverage. I think the problem with, and what I do, I do a lot of stuff that's publicly funded. So I work in a hospital system. I treat maxillofacial trauma, major infections, pathologies, jaw anomalies, things that are covered under the OHIP, under Ontario Health Insurance Plan. But there's certainly a huge void and a need for some coverage. I think the problem currently with this plan, you can correct me, is I think the rollout's been disastrous. I think I have patients coming into my practice each and every day who are under the impression that everything's going to be covered because that's what they've been told. And they may not have been told that, but that's how the messaging's come across. So for example, I can tell you dental implants will never be covered by this plan. Zero chance. Some of the cosmetic or aesthetic things that you guys do won't be covered. Some of the root canal treatments that you do won't be covered.
Absolutely.
And the messaging has they've missed the mark in so many ways. And the problem is you have a plan, you have a population that's in such need, and the people who are helping to roll out and develop this plan, I think, and this is a personal note, have dropped the ball. And I think we're gonna have to do a bit of a rejig of this to roll it out more appropriately. The other concern I have is that, working in a hospital system, this concept of hallway medicine is real. Like you come to the emergency department, you've had an accident, you've broken bones in your face, you're waiting 8 to 10 hours to be seen, right? There's hospitals in the province that don't have MRI machines. And we're throwing money at another area and where there's a need, but I don't think it's been done appropriately now. So it's a real problem. Our healthcare system is in a lot of trouble.
Yeah, I mean, every decision that's made and how to spend money is a political one, right?
Yeah,
These are
100%.
political decisions to try and decide how are we going to spend the money that we have, revenues from taxes. And the federal government made a decision that they're going to try and make some headway into these gaps in coverage because they wanted to stay in power. They made an agreement, the Liberals and the NDP made an agreement to say, okay, we're going to achieve some progress with dental care and pharmacare and roll them out incrementally as this sort of coalition has come across. So it is a political decision, and the federal government has no authority over hospitals. That's very provincial.
Yeah.
So the federal government can only do what's in their authority in this federation.
So what about this business of dentists not signing on board? Will you register, Dr. Shu?
At the current state that the plan is in, I would say the vast majority of dentists are not going to. And there are multiple reasons why that is. As dentists, we're so thrilled that there is now going to be some funding for underserved communities. And small problems, when they're handled early on, remain small. And so if they're left, they become big problems. That's when the root canals are needed, the extractions and the dentures and all that. But if you catch them early on, then that's the best thing for them. And so it's wonderful, and we're so happy that this is happening. But it's just the way that it's done. So, the one insurance company, Sun Life, that's involved in this is, it just has certain powers that sort of don't mesh with our ability to provide a certain service and a certain care. Our purview is to provide dental care and to do the best thing we can for patients. Sun Life's purview and other insurance companies, I mean, they're at the top level, their purview is to make money. And so you can't have that company or that industry making the decisions of who gets care and who doesn't and for what reasons. And so some of those things are, that are involved are in that regard, that becomes obstructive to us wanting to join because we don't want anyone telling us, or we don't want that kind of influence that can negatively affect our patients.
Right.
Another thing is some of the other parts of the program that allow, for example, audits. If there's an issue, typically the governing regulatory bodies, such as the Royal College, is able to come and audit us and find out if there is a problem. And so if the insurance company finds a problem, they go to the college first before they come to us. But under this plan, they can audit us directly at any point. There's a dentist in Newfoundland that started the program as soon as it started, May 1st, and he did 10 procedures, was audited 4 times, which is very unusual, and it's intrusive, and it doesn't.
It's time consuming.
And it's
And
time
paperwork,
consuming.
right?
It's paperwork.
Absolutely.
And the unfortunate thing is the patients have become the pawns in this.
Yeah.
Everyone at this table and any dentist that you speak to will tell you there's a need. There's for sure a need for a program like this, and hopefully we're going to get to a place where it works. But the patients are the pawns right now, and it's unfortunate, I think.
And because dentists aren't joining, what's happening is that patients are finding it necessary to look for dentists who are actually joining, and they're going to have a hard time finding that until all these issues are resolved. And so currently, I think there's certainly been some talks between the provincial and the national associations who have a lot of expertise in this area to help manage this plan a little bit better, maybe help direct it. And I think there's been responsiveness from the federal government, and we hope that continues because this could be beneficial to Canadians as a whole.
But I think we also need to be perfectly clear as day that there will be copays. It is not free. I mean, even in my own private insurance plan, only 50% of major dental is covered. So when they talk about free dental care, there is that misunderstanding there. All right, we're going to take a short break. Stick around. We'll be right back. Welcome back. It's that time in the show when we hear from you, our audience. And first we have Bentley. Hey, Bentley.
Good afternoon. My question is for the dental surgeons. In a reasonably healthy older adult, what causes an implant to fail?
It's an excellent question. There can be a multitude of things. So the first, I would start by saying it's pretty rare to have a late failure of a dental implant if it's placed in an ideal field, ideal amount of bone in a healthy mouth. The things that can cause an implant to fail late, inflammation. So other issues inside the mouth being a problem, gingival inflammation. Number 2, I mean, there's some discussion of occlusion of bite forces that can, depending on how an implant has been placed and how it's been loaded or restored.
Bite force, meaning how
hard we bite.
How hard we bite, okay.
And not only how hard, but how the bite is affecting or acting on that implant and on that tooth. And certain bite forces, certain directions of bite forces can lead to some bone loss.
But usually we don't know.
Yeah, a lot of times you don't know.
So a lot of times when an implant fails, especially if it's been in service for 5, 6, 10 years, we don't know. It just gets an infection and it fails. They can break. That's unlikely.
It's really rare, though. I tell patients when they're sitting in front of me, I'll get the question, how long will this last? My goal is that this will last forever, but not everything's forever.
What about grinding?
Yeah, again, the correlation's tough to know because we see some patients with wicked bruxism or nocturnal grinding. Their implants do fine. I usually will encourage, if someone's investing money in an implant and the crown or crowns that are going to go on top, a night guard or a little appliance they'd wear at night.
Or a little Botox.
Or a little Botox. Either of those things to help mitigate the grinding-related issues are important.
I think it's also worth mentioning about smoking.
Yeah. Yeah, I think smoking, any kind of oral habits, comorbidities, healthcare issues, ones that have an effect on the immune system. We do know there's been some really good studies done that have shown, for example, smokers and diabetics, their early implant failure rates are about 2 or 3 times higher than average. So instead of 3% failure, they're about 9 to 12%, and the late failures are also a little bit higher.
Okay. Bentley, thank you for your question. Let's move on. We have an email question from Darlene. Here's what she writes. I am being treated for oral lichen planus, and it seems to be only holding things at bay. Is there any hope for a cure, or at least a less troublesome treatment? Plus, I have patches of roughened skin elsewhere. What's the likelihood those are also lichen planus?
Yeah, so lichen planus is a chronic, thought to be autoimmune condition that affects mucosa, can affect skin. There's no cure. There's great management for it, so great management strategies, which involve sometimes oral rinses, topical ointments, medications. I would say if you're having issues in other areas as well, probably see your family physician, try and get into a dermatologist to have a look. But it's a manageable condition, but unfortunately not one that can be cured.
Well, most often it's usually picked up by a dentist and then either referred to an oral surgeon like Dr. Rittenberg or to another oral medicine and oral pathologist, which are also helpful. Some of these lesions can actually be asymptomatic, so you might not even know that they're in your mouth. And sometimes that they can exacerbate and become even worse and lead to ulcerations or lead to things like wearing oral appliances very uncomfortable.
All right. Well, we'll have to leave it there. And I'll say this, the bottom line is there is no health without oral health. So remember to take the time to care for your mouth. It is worth it. And that does it for us this evening. To get in touch, you can send us an email at comments@thezoomer.com. As always, thank you to my panel and to you at home for watching. We'll see you soon. For now, it's time to zoom out.